Hello, my name is Amber. Today, we will be debating why it is important to have good team collaboration. I will be the introducer. We have two summarizers, Maddie, who will be sharing the pros, and Deanna, who will be discussing our cons. Jessica is our illustrator. She will be sharing important graphs we found in our research. Emily is our researcher. She will share important points from our research. And lastly, we have Hillary, who will be asking some common questions related to our topic. First, I would like to explain what we mean by collaboration. Collaboration is when more than one professional discipline is on the same team. For example, a student with ASD might have a speech therapist, a psychologist, a special education teacher, and a behavior consultant all working together to find proper intervention. Collaboration can sometimes be difficult, as everyone may have different ideas about treatment. Let us begin the debate by asking our summarizers, how can you ethically and with fidelity design and implement interventions without adequate assessment and lack of resources? Maddie, we will start with you.
Thank you, Amber. First, I would like to mention some of the benefits of collaboration. Collaboration among professionals and caregivers can increase communication overall, open the floor for others to express their ideas, and for everyone a part of the team to stay up to date with the client's progress. There are studies showing that collaboration between caregivers and teachers lead to a decrease in problem behaviors in both school and home. This would make sense because if a teacher and caregiver are consistent with communication and updates about progress and treatment, caregivers can carry treatment out in the home. Collaboration among professionals can be just as important as well, especially when implementing and designing interventions in which you may lack resources. The reason for this is because if you lack resources, it can be very important to contact other professionals on the client's team for updates and information about the client's history just in general. Collaboration is important because you are able to reach out to others to obtain information about previous interventions that may or may not have been successful in the past, and you can get an idea of what resources you can get in a hold of so you can do an assessment and further create an intervention.
Jessica, can you show us what the data looks like on this subject?
Sure. So I'm going to show you a visual support to help better support Maddie's statement surrounding collaboration. This visual was selected to demonstrate how positive behavior supports can help decrease problem behavior and increase appropriate behavior through the works of collaboration in school and home settings. This came out of the Blair article, 2011. The baseline section of the graph included taking data on 3 individuals in their natural environments, in home and at school. The intervention data focused on all of the following for the individuals and their supports involving a collaborative team building centered planning, FBA and hypothesis development, intervention testing, and behavior support plan development and implementation. And that comes from page 26 out of the Blair article, 2011. A concurrent multiple baseline design was used across 3 participants. The white colored trend lines indicate appropriate behavior. Appropriate behavior was defined as engagement in the activities and social interactions, page 24. The black colored trend lines indicated problem behavior, which included self-injury, disruption, physical aggression, and noncompliance. The circles indicated behavior occurring at home, and triangles indicated behavior occurring at school. All 3 individuals had similar baseline data. Appropriate behavior was all under 20% of intervals. Problem behaviors range from 65% of intervals to 83% of intervals. After implementing collaborative interventions, all individuals showed a decrease in problem behavior and increase in appropriate behavior, which was indicated by a drastic level change in the data. The follow-up or returning to baseline conditions indicated all 3 participants continued having decreased problem behavior and increased appropriate behavior when comparing it to the baseline data. The data proves that family and school collaboration involving team building, FBA and hypothesis development, person-centered planning, behavior support plan development and implementation, and intervention testing can decrease problem behavior and increase appropriate behavior. As Maddie had mentioned, collaboration is super important, especially consistency across school and home. The data supports Maddie's statement surrounding the importance of collaboration and how it can decrease problem behaviors.
Deanna, what are your thoughts?
Maddie, you made some good points about collaboration and its benefits. However, there are some disadvantages. Research has shown that there can often be a disconnect between professions, such as a lack of training or just an understanding of all the professions that are involved. This can further lead to communication barriers, which will negatively impact the clients. The client may be negatively impacted based on the interventions that are created and or how they are implemented by each professional. As per an article about multidisciplinary tuning, the authors stated that behavior analysts, one struggle is the language used within the profession, causing barriers between collaborating. That's from LaFrance, 2019. Scopes of practice within fields of behavior analysis, such as are also psychology, speech language pathology, and occupational therapy are also in ways similar, which increases sensitivity between professionals, decreasing the need for collaboration. In a survey that was conducted with behavior analysts, the majority of participants noted that they hadn't received any type of training that involved collaboration, despite collaborating on a day to day basis. With a lack of resources, training, understanding, sometimes respect, and communication between all professions, it runs the risk of providing more harm to the client than good.
Jessica, did you have something to share with us?
Yes, thank you, Amber. Table 4 was chosen to better support Deanna's statements revolving around the challenges of collaboration in the field by looking at each common professional's job description. The table displays how behavior analysis relates to psychology, speech language pathology, and occupational therapy in the light of collaboration. If collaboration is not being properly exercised, the client is at risk for not getting the highest quality services possible. According to the table, behavior analysts focus on behavior, environment interactions, and functional relations. This is from the LaFrance article, 2019, page 723. Psychology includes differential diagnosis, testing of personal characteristics, IQ, personality, and aptitudes, counseling, psychoanalysis, psychotherapy, and hypnosis. Speech language pathology includes diagnosis focused on structural and cognitive corollary issues related to feeding, swallowing, and communication. Occupational therapy focuses on diagnosis, structural, musculoskeletal issues, and skill building related to health and participation in an individual's occupation. The dashes on the table indicate no overlap was identified. Behavior analysis techniques can be applied in multiple settings and among many individuals. Psychologists, speech language pathologists, and occupational therapists do not necessarily need applied behavior analysis to carry out their professional goals for the client. They use their own methods to apply their techniques. An example mentioned in the article on page 721 was this. A board certified behavior analyst has not likely received formal training in the assessment and treatment of apraxia or swallowing difficulties. A speech language pathologist, however, has the training and experience to address these issues. A psychologist may be best suited to obtain information about performance on standardized assessments, and an occupational therapist may be best able to troubleshoot issues related to motor planning and coordination. Why is this table and example significant? The table describes each of the professions that commonly overlap into applied behavior analysis. It was directly chosen to show how behavior analyst scope can overlap into other professions and may help other professionals to do a high quality performance of their job. If the behavior analyst in the example was not able to collaborate with the speech language pathologist, it would make it difficult for the behavior analyst to implement ethically sound, individualized programs for the individual. This would cause the individual to not get the extra assistance in this area.
Maddie, did you have another point to share?
Yes, Amber, I did. Thank you. When discussing collaboration with families, it is important to be aware of ethical guidelines to help prevent an ethical dilemma in treatment. Another great reason why collaboration is so important with professionals and caregivers is so, as a professional, you are aware of the families and clients' ethical guidelines. Without adequate and consistent communication with caregivers that is given with that good collaboration, a professional may be unaware of a family's ethical background, values, and beliefs about how to proceed with an intervention or any situation. There are many ethical codes that a professional must be aware of and follow when working with families that states you must actively acquire knowledge and skills related to cultural diversity. I know I have worked with clients with ethical backgrounds that do differ from mine and wanted to change parts of an intervention based on those beliefs and values. For example, during a food training, a family specifically requested that their child show interest in bread due to a religious ceremony that the family attended often. Another example I have is a client of mine who was learning what objects belong in different rooms of the house. The family asked for specific items to be taught because they were of high value for that culture. And these wants and needs for the families would have been harder to come by if collaboration was weak.
Deanna, what is your opinion?
When discussing collaboration with families, it's important to note that not all the families will be on board and agree with the interventions that are suggested by the team. This, in turn, can establish barriers in respecting the family while also wanting to provide the best quality of treatment for the client. Refusal from families involving particular interventions can potentially put the client at risk, especially when these interventions involve reducing a challenging behavior. As you mentioned, there are many ethical guidelines that professionals must be conscious of when working with clients, colleagues, and families. When on the topic of being mindful of a client's culture, the professional must be self-aware of their own biases and how that this may negatively impact the client's progress. Um, Another point to look at is autonomy. The BACB Ethical Code 4.02 states that the client and or the families are to be involved in programming. The clients and or the families have a right to accept or reject programs as well as make suggestions for skills that the client would like to improve on. What's important to note is, are the professionals taking these ideas into consideration, as this can play a role in the willingness for treatment?
Now let us discuss the use of restraints while collaborating. Quite often, restraints are used on individuals to keep them safe. In ABA, we do not use restraints unless it is proven necessary by our data. In other professions, restraint might be an acceptable intervention to start with. So, Maddie, Deanna, how can you best address restraint and seclusion procedures when the team favors their implementation? Also, how can you support the non-use of punishment procedures prior to exhausting all antecedent preventative interventions? Maddie, we'll start with you.
Thanks, Deanna. Or I'm sorry, thanks, Amber. When clients engage in any form of SIB, it is very important to come up with an effective treatment and quickly. However, restraints may be needed immediately prior to coming up with an intervention due to the severity of the harmful behavior on the client and possibly others in the room. When being a part of a client's team, whether that's another RBT, BCBA, or it could even be occupational therapist, physical therapist, or even a teacher, it's your job to know about the type of restraints being used when the client does engage in SIB. In these situations, you do not want to wait because more injury could occur during the search for a proper intervention. Using a restraint could help stop harmful, unwanted behaviors while the team finds a better intervention. However, not everyone will need restraints. Depending on the level of severity, blocking may be sufficient. benefit of using a restraint is that it does stop the damage caused by SIB and gives time for the body to heal if any injury has occurred. This allows time for a proper FBA to be implemented so a more desirable intervention can take place. However, restraints may not be ideal for all clients, and that must be kept in mind for everyone on the team. Because of this, it is best to use restraint fading along with restraints. Restraint fading is when you slowly fade out restraints. Fisher et al. In 1997 states that restraint fading may be one method of mitigating potential adverse side effects while maximizing the benefits of mechanical restraints. This brings me back to the questions Amber asked me earlier. First, how can you best address restraint and seclusion procedures when the team favors their implementation? And secondly, how can you support the non use of punishment procedures prior to exhausting all antecedent preventative interventions? Yes, there may be times in which the team prefers their ideas on what to implement versus your ideas, and that's okay. An important thing to note is to always stay open minded to everyone's thoughts and ideas. I would say the best thing to do in that situation is to just listen to their thoughts about the implementation and why they think it might decrease SIAB behavior. In my opinion, the best way to show support to people on your team is just to listen to their reasonings behind their thoughts. However, I also wanted to note very quickly that it's okay if you decide to go with another person's treatment plan that's on the team, but very important to keep in mind that per ethical guidelines, whatever treatment is implemented, it must be evidence based.
Emily, what do you have to add?
Thank you, Amber. During my research, I found in the CCBS's position summary on the use of physical restraint procedures in educational settings, I saw that restraints are commonly used in emergency situations where the individual being restrained is very clearly putting themselves or others in danger. When a restraint is used, that threat to self or others is drastically reduced quickly, limiting the risk of injury to the client or surrounding peers and adults. Restraints are also often used when less intrusive de-escalation methods have already been unsuccessful. When attempting these unsuccessful de-escalation methods, it is great to keep in mind that the risk of harm to the client and others can be prolonged when in reality what we're trying to do is decrease this dangerous behavior.
Okay. Deanna, what is your response about restraint use?
So, although restraints may be necessary when a client is engaging in behaviors that is causing harm to themselves or others, there is a risk that if the restraint is not conducted properly and safely, the restraint can cause injury and, unfortunately, on some occasions, death. In an article discussing restraints that were conducted in schools, it was documented that from 2003 to 2017, there were 28 students' deaths. That's from Kern 2020. There's a belief that restraints can also cause psychological harm, meaning that it's a long term effect. These were from reports from individuals that were restrained as well as individuals who conducted the restrainings. There's have also been concerns about the misuse and the overuse of restraints for behaviors other than injurious ones. These are disruptive behaviors or just simply following a demand that was placed.
Emily, do you have something to share?
Yes, I would like to touch on the psychological impact of restraints. Psychological trauma due to the use of restraints has been reported from CUSAC 2018. CUSAC highlighted feelings of dehumanization and a perceived lack of empathy from staff during and after restraints were utilized. Commonly, feelings of distress during and after restraints were reported, causing clients to have heightened anxiety, hostility towards staff, and feelings of distrust. These psychological impacts of distress, fear, panic, and dehumanization led clients to feel as if they had a loss of power and control over their own bodies and feelings of being ignored when in distress.
Now Maddie is going to share with us her ideas on supporting the non-use of punishments. Maddie?
Hi, Amber. Thank you. I want to specifically talk about how collaborating with others about the use of non punishment procedures can lead to discussion regarding the client's treatment that may or may not have been discussed before. The use of punishment procedures like restraints may be a go to for some practitioners since it does help stop the SIB behavior quickly, but it may not be for everyone. From a behavioral standpoint, we may be concerned about the limited use of the client's own body and their dignity when using things like restraints. Restraints may also cause long term damage to the area of the body that it's being applied to. And in some situations, we must do a cost analysis and see that the immediate need calls for that specific intervention to use those restraints. While restraints are being used, it gives us an opportunity to introduce new ideas to other practitioners and discuss ways to decrease SIB without the use of restraints. Through effective and consistent collaboration, practitioners and others a part of the team may have a chance to learn about non punishment procedures during this time. It can be extremely helpful to get views from other people who've not only had experiences with non punishment interventions, but also their thoughts from individuals in the field in general.
Deanna, what are your thoughts about the use of restraints?
So not only is harm and injury a concern with restraints, as mentioned before, but so are the costs. Costs for training in any setting, whether it be a school, a clinic, or in a family's home, it can be expensive. There's also the expenses for any property damage, as well as liability and medical for injury to the restrained or the restrainer. With initial proper training, the other costs of damage and liability can be avoided. With the lack of training, schools and clinics run the high risks of turnover, then leaving them short staffed. And once you have short staff, many issues arise, including the cost of hiring and training new staff, as well as risks of harm to clients and the remaining staff.
Jessica, do you have a graph to show us?
Yes, Deanna had mentioned how cost is an important factor in providing the resources to implement restraining procedures. This graph was chosen to support Deanna's findings and illustrate how restraint procedures can put a financial strain on companies or establishments. This graph specifically focuses on the cost of lost time and replacement labor costs at one company implementing restraint procedures. The company was composed of approximately 250 employees, and approximately 75% of the employees were direct support professionals implementing the restraining procedures. And this is all coming out of the Saunders K article 2011. The first bar on the graph was the year 2004, which contained lost time and replacement labor costs at $171,754.80. This number is significant on the graph because it is the only year restraining interventions were taking place in a natural environment. Because the company wanted to rid or lessen restraints. 2005, 6, 7, and 8 were years in which a new intervention of fading the restraint procedures occurred. In 2005, the total cost was $40,950.08, which traveled in a decreasing trend, ending with $13,154.56 in 2008. This graph indicates removing restraint procedures decreased in cost over a 4-year period and proves the cost of restraining procedures can be of high cost due to staff injury from implementation. Deanna made a great point by mentioning cost is a significant factor when considering restraint procedures. The table was chosen to give the audience a better insight on how high costs can be when restraint procedures are being implemented versus fading them out.
Emily, what does the literature say about the use of restraints?
Restraints can show a drastic decrease in self-injury due to physical incapacitation, causing the inability to engage in dangerous behaviors. When utilizing restraints, restraint fading is important to decrease the level of restraint that can cause harm to the person being restrained. Fisher et al. Highlighted that restraint fading can also identify changes in self-injury topography due to the use of restraints and fade or change restraint techniques. In this study, it was also shown that restraint fading showed a decrease in the physical negative effects of restraint, such as skin breakdown. Fisher et al. Explained that fading the restraint level could have heightened generalization for limiting self-injury by allowing a client a gradual increase in freedom of movement.
Deanna, did you have more to add about restraint use?
Yes, thank you, Amber. One last point I have is from an article by the CCBD stating how there's no true proof that supports restraints are therapeutic. Due to the improper use of restraints and the rates of injury and even death, this raises concerns of the client's human rights. It is noted that restraints should only be used when the risks of injury to the client and staff are significantly higher than the use of restraints. A major ethical dilemma is the lack of research about the use and safety of restraint procedures, as well as there being a lack of documenting about individuals who have received training on proper restraints. Per the BACB Ethics Code 1.01 Reliance on Scientific Knowledge, BCBAs must implement interventions that are ethically proven and research based. Implementing restraints prior to other de escalation techniques can result in a violation of the codes.
Thanks, Deanna, for your opinion about the use of restraints. There has been a lot discussed today, from speaking about the pros of collaboration and all the benefits that it brings, to then about non punishment procedures and it not being the go to for treatment, to then finally about the use of restraint procedures and how they can be very beneficial to a client, yet so many concerns can arise as well. With all that was debated today, I'm sure some questions have been asked. Hillary is here to answer any questions those may have regarding today's debates.
Yes, thank you. One of the questions is, are there other disciplines that might be easier to collaborate with other than a restraint? And the short answer is yes. While restraints may not be ideal for some parties, there are other disciplines to consider prior to jumping to a punishment procedure. It all comes down to research, clients, and other parties involved. We must always consider the best interests of the clients per the BACB code. Another question that might be on others' mind would be, what might make some disciplines easier to collaborate with and others not easy to collaborate with? And there are many factors that go into collaboration. And Bailey and Birch 2016 go over some of the factors that go into collaboration and procedures. Some things that have to be considered are the culture, religion, and the personal lifestyles. In the end, communication is key to finding out what is going to be the best way to collaborate to help aid in the success of the collaboration and, again, the best interests of the clients. A third question is, what are the ethical codes and guidelines and how are they developed? Well, there's the personal ethics, which one learns as they grow. And then there's professional ethics, which is how we act within our work environment. Some examples of personal ethics are learned through families, friends, schools, churches, and essentially they're right versus wrong. With the professional ethics, there's expectations within a work environment and how one presents themselves to clients and parents and coworkers, and how they act with the supervisor present versus not present. But sometimes these blend into each other. An example of this would be white lies and gossip. Excuses for not wanting to do homework to getting an extension that can fade into a work environment when the individual is late to work and has an excuse for why they're late, which may or may not be true. Potentially, it's just as easy as oversleeping. These personal and professional ethics are discussed within Bailey Birch 2016 as well, and they provide more into it. Ethical guidelines and codes are developed with these in mind, but also with the best interests of those being served. The BACB ethics were developed as a guide to help lay down a foundation for professionalism when working with individuals with autism and other developmental disabilities. Another question that might be on others' minds are there benefits to collaboration with other professionals? The answer is yes. This goes into the code provided by the BACB. One code is accepting the clients, which is when individuals will seek out from a BCBA, and part of that code is to accept the client and knowing they are seeking the recommendations from the BCBA with the correct knowledge and skills when working with this individual as well as other professionals. All professionals have their own knowledge and skill sets. So when working with other professionals and working with clients who are seeking the recommendation from a BCBA, the BCBA has their own knowledge and skill set of their own. And so when they collaborate with others who have a different knowledge and skill set, which will help establish an intervention for the client, and we have to accept them and everything they come with. Another code provided by the BACB is Responsibility 2.02, which states that it's a behavioral analyst's responsibility to all parties affected by the services, and this includes working with other professionals to best aid in what will be beneficial to the client. Another code is 2.03, Consultation. Behavioral analysts arrange for appropriate consultation and referrals based principally on the best interests of their clients, which means we'll have to be collaborating with other professionals. We have to have the appropriate consent that has to be considered when working with the other professionals. We can't just go into working with the other professionals due to HIPAAs and other violations. We have to maintain that confidentiality, which is another code presented by the BCBA, and it's code 2.06. Again, maintaining confidentiality. We can only give out the required information with the correct permission between the different parties. Therefore, a parent needs to agree to the collaborations between the other parties and the BACB or the BCBA. Another question would be, what ethical principles are in conflict with restraints? Again, going back to the BACB code, 1.01, reliance on scientific knowledge, which means all programs and interventions derive from the research. What this means is that all programs and interventions that are in place is an evidence-based intervention. Research and peer reviews were done, and the results had shown to be effective for certain behaviors. This is in place when looking at a restraint as an intervention. Therefore, the proper use of the restraint without prior knowledge or training to implement the restraint could cause for conflict. Going back to the BACB code 1.04, integrity. A behavioral analyst has to be truthful and honest and arrange the environment to promote truthfulness and honesty among others. It is the responsibility of the BCBA and those implementing the restraint to be honest if they have not been trained on how to do the restraint or they don't feel comfortable to do it. It is our responsibility to communicate that. For the last question that may arise is, does using restraints first cause an ethical dilemma? This is going to go back to the Code of Ethics and the BACB. One code is 7.02, ethical violations by others and risk of harm, which states that if a behavioral analyst believes that there is a legal or an ethical violation that must first be determined, whether there's a potential for harm or a possible legal violation, then the restraint shouldn't be in place. What this means is that if a restraint is in place when there doesn't need to be a restraint, then they are breaking the Code of Ethics, and there is an ethical dilemma to that. Going back to the code within the ethics 4.09, least restrictive procedures. This just means that we have to be using the least restrictive procedures first whenever possible. However, safeties and concerns is going to trump everything. We have to keep the client safe. We have to keep our workers safe. We have to keep those around us safe. And so sometimes we may have to use the restraint first. And it's not an ethical dilemma in that case because we are using what is we're using our best judgment and our best consideration in order to help guide us. Another code to consider when you're looking at restraints as the first priority is code 4.08, the consideration regarding a punishment procedure. Behavioral analysts have looked at the reinforcement first rather than punishment whenever possible. Again, safety is going to trump everything. Thank you for watching and listening to our debate. Here are our sources.